Hi, teacher. Good night.
Yes, hi again. How are you?
Hi.
You are the
I'm
first.
fine, and you?
Yes, I can hear you clearly.
How are you?
Fine. Tired, but I think it's just a custom now.
Tired?
Yes. It's not easy when you have children.
How many children do you have?
3 children.
Oh, how old
Two,
are they?
I have a teenager and 2 babies.
Oh, a
Yes,
lot
and
of.
it's not easy. It's a very different behavior between my child. So my babies are 2 girls, Valentina and Micaela. They are extremely crazy. I mean, they're running me crazy. I'm without hair. I'm nervous and stressed because I'm trying not to let them get killed. They start walking. One is a year and a half, and the smallest has 9 months. So both of them are moving by themselves. And I have to
Oh,
run. I don't know which one to go first. It's not easy.
they are like twins.
My teenager is a boy, so you can imagine it's very different, the behavior and the way he thinks about everything. A very complicated age.
Yes, it's very. It's hard that age to
Yes, it's not
understand them.
easy.
No.
Yes, he tries to do his best, but he gets nervous. He doesn't understand what's going on, and it's not easy. I mean, I remember when I was a teenager, and I understand him. In all ways, he tries to do something. But it's
He's at the school
a good situation.
now.
Yes, he just finished the 5th grade. He's in primary school now. And
Okay.
well, now we are relaxed because there is no more runnings in the morning.
They finish
So
the
yes,
school,
academic
right?
school. Yes, the 2 days ago, I mean.
My sisters are still going at the school.
Yes.
I think yes,
She's
they are
now going.
taking their final test.
Okay. In which school she is now?
She are primary school, and my sister she has 17. Is her last
Okay.
year.
Okay.
She's gonna finish this Friday, and my other sister's going to finish next week. Next
Oh,
week.
fun. I'm glad my boy is not going now.
Yeah.
Okay, but that's okay. So
Yeah.
we are now 9 people. That's great. So how you feel from yesterday? Hi Ruth, Ariana, Fabi, John Harold, Catherine, Johan, Belkin.
Hi, how are you?
Fine, Ruth. Little tired, but everything's okay. You look better now.
Yes, yes, I feel better.
That's great.
You.
You're recovering nicely.
Yes,
That's great. That's good news.
yes. 7 days
So,
before. After.
no, that's okay. So, yesterday we were supposed to fill the final pool from the module 1, and certainly I forget it, as always. Please, I'm gonna send it, and I need you people to fill it at the beginning, right? Please, I'm sending it now. Can you watch this? There are 1, 2 questions. I don't know, don't remember. Yes, 2 questions. Yes, 7 with it. 1 more, yes. What happened? Okay, I have 7 people. Okay, that's okay. And John Harold, everything's okay? Vamos a preparar esto primero.
Yes, teacher.
Yes, you're welcome. I was telling the classmates to fill the Module 1 final pool. Yesterday we were supposed to do it, and certainly I forgot it. Can you fill it now? Fill it now, it's open. Can you watch this?
Yeah, I feel it. So,
Oh, perfect. Thank you so much. We have 8 minutes, okay. Thank you so much. At the end, I think we can continue because we are 8. So tonight we have a new model, as I was telling you. We're starting the second model, the model 2 of this course. And of course, we're going to work a lot on this because now it's a new kind of view. I mean, we have the basis, the basic idea about the whole vocabulary in the medical terminology, anatomical reviews, and many specific situations according to these specific ways of talking. Today, we are going to start talking about the studies, the research, and everything that are the complementary studies for the tests and for readings and this kind of structures. And of course, we are going to start with the clinical history and its writing. We started with the case report, the basic part of this structure, but the most important one for having all the information with coherence, right? So it's important to understand that we are going to write down a lot. It's not going to be as in the first model, for example, crossword, scramble words. It was easier for that way of topics. But at this moment, it's important to start writing down and practicing and going ahead with this way for getting the capabilities well done, I mean, and having all the ways covered. I mean, not as the way as I would like to, because it's not too much time for doing it. We have 16 meetings just, but we have to try to get it in the way that we use it as much as we can, I mean, right? So any doubts you have, any questions, something is not clear or something you would like to add, please let me know and we can consider it and change the program of the studies. Today, I've been preparing an easy presentation, not too long. I hope we can finish it in an hour. Because I know we have many things to do and you want to read and check. Can you watch my screen?
Yes.
Yes.
Yes, for one, right? So in that way, let me open it. We are going to consider that it's a new way, a new perspective, a new vision I'm trying to get into this course for practicing more. And that's the way we start. We have the contents of two of these sessions just at the beginning. I mean, this one and the next one with more situations. Basic investigations, lab tests, endoscopy, X-ray, CT, MRI, and ultrasound, and ECG. Of course, we are not talking about all of these situations. We are going to talk about basic investigation just. Lab tests and endoscopy, I was trying to prepare it, but it loses the focus while talking about basic investigations, because we must understand what's the meaning of this expression. That's why lab test and endoscopy is going to be taken in the next class, taking coherence with the rest of the topic. So you're going to see it's going to be more dynamic, because I need you to practice and give me opinions about findings we are going to study. For example, in X-ray and sounds and CT, I'm preparing pictures with lots of diagnosis, and I need your help for working with that. So let's go ahead. Basic investigation. What do we understand about medical investigation? What it means for us? Anyone who would like to say, what's the concept you have about medical investigation? Maybe it's not the same as everybody. Maybe it's just an idea that we are complaining, that we are, I don't know, getting inferred, but not having as a real concept about the real importance it has. Because I know it's not a common topic to talk about it, what we are really doing with our career. So, for example, the investigation, the meaning, I mean, is the systematic and thorough examination or inquire into something or someone, the collection of facts or information, and the recording of this examination or inquiry in a report, right? So we have to get in order information, get in a systematic way all the data we need, all the topics we are looking for, on systematic and thorough. So we have to take it as an idea that if we lose data, if we don't make the correct questions, or if we don't make the correct order of the situation we are treating, we are going to lose information and everything is going to be wrong. So just for information, the word investigate can be traced back to the Latin investigare. And it means to search into. And investigare is based on another Latin word that is vestigare. That means to track or to trace. So we have to understand that the investigation is to make a line with the information to get a correct chronology of the events, and then we can get a correct conclusion. In our case as a doctors, a correct diagnosis. So a medical investigation is, of course, all the complementary studies that we request in order to support the diagnosis. For example, we receive a patient, and this patient is complaining of back pain. I don't know, and it's something very common. A back pain, a lumbar pain, I don't know. And we start asking for when it begins, the intensity, the radiation, and all of the things we know. But we have to get in order that questions for having the chronological way it has started, began, and continued through the time. And of course, we don't have to lose any data. We have some mnemotechnics, for example, the Alicia Fredusa, very common in this in Latin America. And we have that ways of, or that order of asking questions, of making questions, and we get the correct information with an easy way to remember all of the questions we must ask. And there is no way for losing data, or no way for the patient forget something, because patients are not going to tell us if we don't ask. We are going to look for this specific information, right? And it's important to consider these situations, all the complementary studies. Of course, imaging, lab tests, scans, specific situations, cultures. It depends on the situation for the topics we are looking for. The first medical investigations we make, can you tell me which ones are? For example, an idea you could have maybe? Something that we usually do by the by the first contact as a patient, and it's a medical investigation, and don't always we consider them like that. Okay. So this is to see if we need to do more tests. Sometimes we must do it, but it's a joke just. What's the first medical investigations we make? The first complementary studies that are not invasive that we can make to the patients in order to have the first idea what is going on with the patient.
Anamnesis.
Tell me, Agar, I'm sorry.
We start always with the anamnesis.
Yeah, the anamnesis, the interrogatory questions is the way you get the information, right? And the patient is complaining on the situation. She's telling you all of his complaints.
Mhm.
That is the way you get the first sight of the problem. When the patient finishes talking to you, what's the next step?
Physical exam.
Yes, the physical exam, perfect. What's the first tip, the first step during the physical examination?
Inspection.
No,
No.
you take the vital signs.
Yes, I forgot.
Don't worry, that's okay. I'm sorry, my typing is awful. I forgot a letter. I'm going to correct it. The vital signs, of course, are one of the most important parts. Some medical school says that it's important to take the vital signs even before the anamnesis, the interrogation time, because we must try to get it when the patient is not nervous, confused, is without the stress about the situation. But some of the other medical schools tell us that we must take the vital signs after the interrogation time. That way of talking with the patient, because the patient gets relaxed and feel that someone is doing something for him, and well, he feels important about the situation. And that's why it's important to choose the best moment in your own practice. For me, it's better before all the medical procedure, at least. The interrogation time, the physical examination, and everything. For me, it's better to start, and please give me a second, I'm going to take the vital signs, and I start with it. With other patients, depending on how they express the complaints, sometimes it's better to look for to practice with them and act as taking the vital signs while they are talking, because they feel better. If you touch them, you shake hands, or you use the blood oxygen, the oxygen saturation device while he's talking and talking and talking, because they feel that they are important, that you are doing something extra. And of course, you are not paying attention to the device, you're paying attention to the patient. It depends on your way of working. But don't forget that these vital signs are the first medical investigations. And of course, we know which ones are them. The blood pressure, the heart rate or pulse, respiratory rate, the core temperature, the blood oxygen, could be the arterial blood gas, or the oxygen saturation, and it's considered now the vital sign. And this one is added because in many cases we really need it at the beginning of the situation during this first control, during this first investigation, right? These investigations, well, of course, has a rate, a normal one and an abnormal one. And we have to consider this. We must treat the patient and not the monitor. I mean the monitor because in so many places, we just use many, electronic devices. We connect the patient and we just talk. And that's not a bad point. That's not a bad idea. But we have to consider that it's okay. It's okay. It's the way we have to talk. It's the resources we get. Usually in Latin America, we don't use monitors, but we use devices, or our nurse is going and taking it in a bad moment. And we have to order the situations, right? So don't forget the abbreviations: heart rate, blood pressure, respiratory rate, oxygen. Of course, not just O12. This is the correct abbreviation. And this is the one I'm going to ask for all the time we practice with this. And the values that is going to help us, just so, because we know this because of practice. In American schools and European schools, they use the Fahrenheit grades, use the centigrades. That's the same. I don't have any trouble talking with one or the other. That's okay for me. It's your choice. For example, we have Alexander Tatarin. That's a great nurse in Europe. And he says that vital signs provide the clinician with an overall snapshot of a patient's well-being and can help determine the treatment and management plans for patients when taken into consideration with the other data points. Of course, not just the vital signs are the most important part of the evaluation of the patient. We know it. We have to consider all the situation as a global situation, could be. But the vital signs at this moment are data just for this moment, not for all the time. And the entire patient as a whole, a complete world. As we were saying, do you remember in the first presentation, we have the throughout begin wellness and illness and everything, two ways of being. That's why he refers as a whole, okay? When vital signs are abnormal, first check to see how the patient is doing. If they appear well, but the vital signs suggest otherwise, remember to treat the patient as a whole and not just individual numbers. Maybe we had trouble with the devices, we are getting wrong data. We could make a huge mistake if we don't consider the situation. So it's important. This first investigation concerned to us in the whole entire world, I mean. And this investigation is the most important part, considering the physical examination too. They go hand by hand, working for having a correct diagnosis. Our first ally in this medical investigations, medical examination, of course, is the stethoscope, our friend. We all doctors have 1, 2, maybe 3, it depends on you. But it's not the stethoscope, it's you. It's you, it's your hearing, how you were practicing your hearing for getting all the sounds by listening this, by auscultation, right? The first stethoscope was nothing more than a rolled up paper, and that's our history of medicine, and that's true. Lenac, this doctor, was attending children with I forgot the correct word, con lepra negra. I don't remember the specific term. And for not getting in contagious ways, for not touching the patients and getting risk, he used to roll a paper and use it. And this was the first approach for inventing the stethoscope. Then he decided to do this device because he didn't, well, he invented it in France by the 1816. René Lenac at the Necker Enfants Malades Hospital in Paris. And it consists of the wooden tube and was monomaural. Lenac invented the stethoscope because he was not comfortable placing his ear directly onto a woman's chest to listen to her heart. So you see this picture. He's placing his face on the chest of the patient. With a boy, there is no problem, but with a girl in that times, of course, it's not a common situation and not a common, a comfortable way of being with the woman or with the doctor. And he said, I'm not going to touch anybody, so I'm going to prepare a device. And this is the device I did. This is the first model, and of course it has many shapes from there. And we have the opportunity to practice with them maybe at the university, or maybe we have one, I don't know. And just an important data for knowing that the objective of this device is not getting in direct contact, skin by skin with the patient and getting contagious. And of course, the stethoscope has its own parts, the air tips, the ear tubes, the binaural spring, the flexible tab and rubber tube, the stem, the bell, the drum, the diaphragm, the dual head chest piece, the tumbleable diaphragm. It goes round and round. So this device, of course, is going with us everywhere, I mean. And all of us has one, and all of us has practiced. It's not true when someone tells me, I didn't do it. That's not correct. When we are in the first year, it's usually to receive one of these devices from family because they say, oh, you're going to be my doctor, it's for you. And that's amazing. And you said, yes, I'm going to be a doctor. I feel so proud about your decision. And of course, we must know it because it's this parts of the device, this anatomical review from the stethoscope. It's just for information, but it's important to know that it's the origin of the way we work now. Of course, we have electric ones at this moment. We have stethoscopes that record the sounds for amplifying the sound on the computer. That's a good advances in technology. But don't forget that those advances are not useful if we don't know how to use it. If we don't use it in the correct place, in the correct moment, with the correct technique that all of us know about it. Of course, knowing the stethoscope, we can take the blood pressure. Maybe the blood pressure, sometimes we don't consider it as an important topic for all of the patients. But of course, we can take it all the time for having an idea of how is the situation with this specific one, I mean. Agar, can you read this slide, please?
Blood pressure is a non-invasive procedure that measures the pressure of circulating blood against a blood vessel wall. The top number, known as the systolic BP, is the amount of pressure that your heart pumps through your arteries and entire body. The bottom number is known as the diastolic BP, is the amount of pressure in the arteries and body when your heart is at rest.
Thank you so much. So we have here the concept for remembering, for refreshing the idea. And we have the definitions in English, I mean. We have vocabulary to remember, to practice, of course, using the abbreviations all the time. And go ahead. How it works. We have these pictures to show us the way it helps us to understand. We have here the sphygmomanometer, the stethoscope, and we can see how the artery is closed, how the artery gets opening and full opened, and when the sound is going to be heard, right? So with this idea, general idea, we can understand how it really works. And then, of course, we have our sphygmomanometer, our tensio, yeah. And we have electric ones, manual ones, and of course we have all of the activities the patients used to do and don't do. So we know about it, just for remembering, for refreshing the ideas and having a big view, a new view of what we are talking about. And the boss says, what says all the people about this situation? What is important to consider according to the American Heart Association, according to the blood pressure. So we have the normal values, we have the abnormal ones, we have classifications, many of them. It depends on the medical school you are talking about, but one of the most important ones is this from the AHA, the normal, the elevated, the high BP, the hypertension is stage 1, stage 2, and hypertensive crisis. So taking it in account, we can know, we can practice and have the correct idea that it's not a shame to do it all this in all the situations we can. It's necessarily to do all the time. And we have to remember these values because we are going to work with all the values. I'm going to try to show you the actual ones, the most data, share with the group, and that's perfect because information is done for being sharing. Don't forget, the normal one is the last classification I found. The normal less than 120 and less than 80. I think it's not a common situation to find this BP now in the community. The elevated one, 121 and 29, and less than 80. You see, it's the same. The high BP, the stage 1, 130, 139, and 80 and 89. So you see here's the difference, just not just a big one. The high BP stage 2, 140 or more, 90 or more or higher, and the hypertensive crisis that I think that everybody treated one of them, a crisis, a hypertensive crisis, and we all know how to do it, how our job must be done. So just for remembering these values, we must consider this situation. And of course, for ages, we have many differences about the values, just for having a huge and big idea, and considering that it's not the same a baby than an elderly, or even a teenager. You can see, not the same from 6 to 90, or better this, 1960 than, 130 with 86. Of course, they're so different. And we have to be with open eyes for practicing it, right? And another topic we are now talking about is the ophthalmoscopy. This non-invasive procedure, it's not always practiced in our communities, could be in our medical centers, not as a common situation to do. Not as a not all the time. With not all the people. We should try to do it because it's important about the findings we can use. The ophthalmoscopy, it's a non-invasive procedure developed by a doctor. It must be done by a doctor because we can support all the things we see, not the reports that the other one makes to us. We must do it by ourselves and see and report by ourselves and practice a lot because it has its own technique. Ariana, can you read please the second paragraph?
Yes. An ophthalmoscope allows the doctor to examine all parts of the eye, the iris, lens, retina, and optic disc. For best results, the examination is done with dimmed or lower lights to allow the pupil to maximally dilate or widen. A topical mydriatic solution might be applied to the eye to aid dilatation. The patient is then asked to fixate on a target for the duration of the test.
Thank you so much, Ariana. Have you ever, any of them, I mean, have you ever been, a patient and a doctor made this practice with you, the ophthalmoscopy?
Only in ophthalmology.
Yes, just in ophthalmology, you were doing it, but you were the patient and it was done for you, I mean.
Oh, yes.
Yes, I remember you told me that experience, Ariana, and it's uncomfortable, right?
Yes. And the doctor is too close to you.
Yes, but we have two ways of making it, the direct and the indirect way. But I mean, when you get these drops, the topical mediatric solution, you cannot see anything, just light, right?
And it burns.
Yes, and you need someone to go with you and wait. Wait as much as you need and time for getting recovered from this situation, and then you can walk, right?
Yes, it lasts like 4 or 5 hours.
Yes, that's true. So we have the ophthalmoscope, its parts, of course, for remembering, just for having the idea that we are the most important that are treating this situation, and we have to know how to work with this, how to open it, how to turn the line on, how to calibrate the depth for making the correct finding, making the correct evaluation, and not making mistakes. And of course, how to catch it in hands and how to place in face and not making the mistake. You have the, as I was telling you, the direct method, going so close to the patient, and the indirect methods. But for this one, it's a terrible experience if you don't have enough practice, because you see everything instead of the eye. So you see, this device is just for showing you the ways of doing. And of course, that's the view we must get. That's why it's important for us to remember the anatomy, to remember everything for going in order to the findings, okay? We have the blood vessels, the physiologic cup, the optic disc, the macular area, and the fovea. This is a picture, but now we are going to watch some images about it. Now we have another view of the findings and the standard components of conventional binocular indirect ophthalmoscope, right? As I was telling you, with this lens, needs more practice, more eye, yeah, more sight, and it's not easy. But you have the way, the true way of doing this. And this is the first picture I want to show you. This is with the mediatric solution. This is how the pupil is completely opened, full opened, and you can watch inside. And you can see the anatomical structures. Maybe John Harold, can you describe this picture, please? John Harold?
Yes. Well, do we have some blood vessels? Like they were a little bit dilated. We have,
Yeah, dilated, yeah.
We have an optic disc that is, I think, normal for me. Macule. Some points of hemorrhage.
Yeah.
And I think some exudates, right? 2 points right there, but
yes, these white ones, right? Here, here, here. Yeah. Many places. Yes. There's the macula, right? This size of hemorrhage is important site, right? This one, what do you consider is this? Is that hemorrhage or it's a vessel?
Their vessels, yeah.
It looks like a vessel, right? So in this order, we are watching a great picture, I mean, because it looks so great. It has a perfect way of considering the anatomical description. And we have some structures to practice on. Maybe Johan, can you listen to me? Johan? Well, maybe there's not a good sign. Fabiola, can you listen to me?
Yes.
Yes, thank you. Can you read the first one of this slide? The one I'm pointing.
Okay. Vitreous. Corals, streaks, or diffuse patches of fluid in the vitreous obscures the retinal vessels.
Thank you so much. So we have the vitreous intravitreal hemorrhage, right? You see the level, you see like a cluster, like a bag that is catching the blood collection. And it looks exactly the same. You find it in trauma situations. Okay, Belkin, can you listen to me?
Yes, I'm here.
Yes, thank you, Belkin. Can you read this second one, please?
Peritoneal subjaloid. Typically single or in small groups, initially round but becomes bolt-shaped over time, obscures the retinal vessels.
Thank you so much, Belkin. So you see this pic. This is boat shaped and it gets in the situation. You find it when you have a broken vessel. It depending on the situation, it's not a very common finding. But when you get it, you must run to an ophthalmologist to get the solution. Catherine, can you listen to me?
Yes, teacher.
Yes, hi, Catherine. Please, can you read this third one?
Okay. Pre-retinal to hyoid.
Yeah, subhyoid, yes.
Tampering on this in diameter, usually in groups of 3 to 8, dark center with glistening light reflex freight edge.
Yes, thank you so much. You see it when you have a brain tumor that is pushing the eye and the retina is going to the front, like a fingerprint. Okay, a fingerprint. Yes, you see exactly the same. And the most pressured place has this red point, the disc. Yes, this disc is the vessel that is getting broken and leaving the blood all the structure. Ruth, can you do the fourth one, please?
Yes, the superficial intraretinal enlarged with flay borders, splinter, or flame shaped.
Thank you so much. So these small points, it's not an easy way to see them because they're too small at the beginning, but when they get big, of course, the situation is going wrong. And it usually happens with the diabetics, with the diabetic retinopathy. Yeah. Johan, now can you listen to me? Well, he's connected, but it's not easy, the connection at this moment. Maybe he's still in job. Well, John Harold would like to read this one. Well, no, man, the second one.
Yes, retinoschisis.
Yeah.
Schisis cavity surrounded by a hypopigmented or hemorrhagic arc, or an elevated retinal fold.
Yes, it looks awful. With this situation, the patient is without vision, is blind, an acute cause of blindness. So we find it and let's run to the ophthalmologist. That's the only advice I could give to my patients or my colleagues. The deep intraretinal dot or blood is the situation that points that must be studied through the time and then consider the real situation and the origin. It's not a very common situation to find, of course. The subretinal, this one, between photoreceptors and retinal pigment epithelium. Red blotches with round lobulated borders beneath elevated retina, usually extensive. It gets bigger and bigger and bigger, and the patients lose the vision, gets blind. Certainly, at this moment, I don't remember the cause. I'm looking for and sending you a message. And the subretinal pigment epithelia, the choroidal, dark slate colored with the smooth borders surrounded by a red ring. So you can see it in this same situation. This gray point is, it could be compared as a dead tissue. So if it's a dead tissue, of course, there's no possibility to get a function on it. This is one of the most important, and of course, if we have the opportunity in our in shifts or in jobs in hospitals or during our practice at the med school, we must try to find it and understand that the diabetic retinopathy is one of the most common causes of loss of vision in young people. And going through the time, it is a cause of blindness. So we must consider that this imaging is very important with these specific structures that we were watching this. Wow, the exudates, right? Here, these white ones are chronic, I mean, and red ones like this are acute. You have here red one exudates, white ones, and you can consider this is a diabetic patient without a correct control. We have these structures, more fundoscopies, watching the changes in the hypertensive retinopathy, considering the lesions through the time, right? The optic disc with the edema, you can see the vessels are dilated, you can see the center that is lightened and a dark ring around. You can see these lines that are silver lines, very, very common. The intraocular hemorrhage, that's very common in situations when the blood pressure goes higher so fast and a vessel broken and then gets this situation. It's not a cause of loss of vision, acute loss of vision, but we must consider for giving the correct treatment. If we consider this is just a small vessel that is broken with a high BP, through the time, the BP is going to get worse and could be broken another vessel, and that's important to check. The optic disc pallor, this is a cause of chronic high BP in bad control. And of course, we must consider when we check our patients, and if we get this imaging, we must reconsider the treatment and how we are controlling the situation with our patients. The grade 3 and 4 for hypertensive retinopathy, you can see the difference from this to this, right? This is acute and this is chronic. Anyone who would like to make a comparison about these two pictures, this one and the other one, considering all the ideas now we are talking about, or maybe you have more information to share with us. Any volunteer, of course, we are taking in count. Somebody? Oh, it's better to point someone. Maybe. Okay, let me ask this. For example, Ruth. Are you there, Ruth? Can you listen to me?
Yes, I'm listening.
Yes, perfect. Have you ever practiced the fundoscopy?
Yes, at the beginning of the career.
Yes, at the beginning.
But I don't know, maybe if I have 4 years or 5 years, I don't made ostoscopy.
No, that's okay, because it's not an easy fact to have the device in our job centers or in our hospitals. It's not a common way to practice and to have the doctors watching into the eye all the time.
Yes.
But if I ask you to make a comparison between this picture that I'm pointing from this one, try to do it. Let's make an example. Try to do it. Try to be more participating, because this module 2 is going to be so participating with this kind of activities, with images and pictures and, well, many situations. And I need you to talk more than the first module. The first module was so easy, reading and sharing, and wow, a piece of cake. But now it's important for us to use all the vocabulary that we were gaining in the first module.
Okay.
Do your best. That's okay if there's not a complete comparison. The objective is not to make you feel embarrassed. No, nothing like that. It's just practicing and remembering. Because I mean, I think that everybody needs, including me, needs to practice and to check these structures again. It's not a common situation.
Yes, well, we can compare the optical disc, and it's bigger and the color is different, and have a halo before the optic disc. And the blue vessels are bigger, and the color of the macula is more darker than the we have in MRI.
Yeah.
And hypertensive, the blood vessels are bigger, and we can see the tophonos.
Yeah,
and it's common, it's common to see in that pathology.
Okay, so we see dilated vessels, right? In all of the structure, losing the shape. Yes, so in that way, we are noticing that this losing shape is a consequence of the control of the BP, of a bad control, or maybe without treatment. We don't know the real situation of the patient. Maybe this patient from this picture never had the idea that he has high BP, and he never take a treatment, and thus he only gets the diagnosis during the consequences. It usually happens.
Yes, that is happening.
Yes, and now you can see the macula, the optic disc. Now here is defined. It's clear, you can find it easily, but here we are a complete loss of its borders, right? It's not easy to define where it finishes or whether which shape it exactly has, right?
Yes.
So this one is a retinal vascular occlusion, so that's okay. Thank you, Ruth. That's okay. So we must start practicing in this way. I'm going to ask you to describe pictures, to describe, I don't know, CT scans, X-rays, echographies, sonographies. I mean, to interpret lab tests, because we are gaining medical terminology vocabulary, and now it's time to get in practice. And during this practice, we are going to write down reports, and we are going to write conclusions. We are going to find ways of expressing diagnosis that are going to be supported by these kind of evaluations of findings, objective findings, not just ideas or meanings, just with data, with documentation. That's the most important idea we must get and never forget. American school, European school always get a diagnosis having the correct documentation, the correct papers that tell us why the situation goes through this moment, why the situation is so bad or so good, or why the recovery is well supported. Not just because I see you, okay. No, there is nothing with I see you. Everything is with papers, with data, with studies, with statistics, and we must consider this kind of a study. With the retinal vascular occlusion, well, that's not a big picture, but it helps. We have dilated vessels, and these structures, these exudated silver ones that help us to understand that this is a space that is not receiving enough blood. In an acute sense, we get the occlusion corrected and everything's okay. And the optic disc pallor usually responds to a situation when the retina gets out from the eye. I don't remember the correct term, but that's the idea. So at this moment, we have these ones, and we have more pictures to watch. We have the description for these situations. And of course, we must consider that in many situations, the REN is acute retinal necrosis. It's not a very common situation to find every day, of course. It's a situation that is very, very disgusting, very, very hard, because you lose sight, the patient gets blind, and usually it's not possible to cure it, to get a solution, to promise a recovery. Of course, we don't have to promise it. We have to work on this and try to do our best. Maria Fernanda, can you read, please, this explanation?
Ophthalmoscopic findings at the time of diagnosis of acute retinal. What was the N? What was the meaning of the N?
Necrosis.
Thank you. Necrosis, optic disc swelling, macular edema, exudation along blood vessels, narrowing of arterioles, dilatation of venules, and superficial hemorrhages were observed in both retinas. Ophthalmoscopic findings 19 days after retinal photocoagulation, optic disc swelling, macular edema, and exudation following the course of blood vessels were alleviated in both eyes. Central retinal vein occlusion was observed in the left eye, resulting in neovascular glaucoma.
Thank you so much, Maria. So you can see the differences that are described here. And of course, you can see the way this description is done. Very technical way of talking with all of the medical terminology we're practicing and learning and writing down, okay? Of course, we couldn't study all of the terms, all of the words, because if we try to do it, we should repeat the medical school, and it's impossible. But we have a huge idea about what we are talking about, right? About the situation we are crossing now and how we are going to write down from this moment. So, I mean, it's important for us to continue and don't forget what is we are supposed to do. And of course, a goal without a plan is just a wish, just a wish. So we must organize our ideas. We must plan all of the topics we are doing at this moment. We must organize how we are going to write down, how we are going to express, especially starting with the key report and then with the description of pictures, of images of studies. And we must consider all the situations I've been telling you all of this presentation. It's not a long one, I know, yeah. I made it in this way because I consider really still tired from the test that was yesterday, a little harder. But it's a good way for starting the module 2. And tomorrow in the workshop, we are going to start practicing these structures, and I'm preparing activities for the workshops. That's why it's important now to get into the workshop. In the first module, we were having the clear of doubts, pronunciation, maybe new words, details that we must practice. In this module 2, we are going to put in practice all the things we were working on. Okay? Maybe any question at this moment? Something you would like to know? Everything's okay?
In the same order that we have in the last letter.
Come on, I'm sorry, I don't understand your
The
question.
schedule
Okay.
is gonna take in the same
Yes, it's gonna
time.
be the same. Yes, it's gonna be the same. I'd rather not to change it because all of us get into organization considering this schedule. If now we change it, maybe because of job, it's not possible for anyone. And of course, if tomorrow, for example, I see the new student that, well, a classmate that didn't come all the course, for example, David, he didn't come in class from the first module. He decides to come now ask for changing the schedule. Of course, I'm going to ask all the group. It's not fair to change because of him. I prefer to do it. I know that I have here 1, 2, 3, 4 students that come to the class during their job. So they are the last ones that get into the workshop. Considering them, I wouldn't like to change it.
Okay, thank you.
Okay, anything more, something extra you would like to know, to ask? Is everything okay? Agar, there's no question?
No, everything is clear, teacher.
Perfect. Ariana, everything's okay?
Yeah, everything's okay.
Thank you. Fabi, are you there, Fabiola?
Yes, I'm here.
Yes, Fabi, everything's okay. Now, I consider you are in the first year of the career, right? And that's okay. That's a good point for practicing and getting lots of details and practice. But we are going to try to adjust the contents in order to help you not to make you in trouble, okay?
Okay, thank you.
Yeah, because I think it could be a good idea for doing it. All of the group, well, we know how is this. Maria, you're in your 4th year, so you are at the moment we are talking, and you are a fresh student for answering everything.
Oh,
The
God.
same with you, Mariana. The 4th and the 5th year are the years of these topics. So you are going to be my bunnies. That's good for you. Don't do it, Ariana. Don't be stressed with this. It's going to be good practice, extra practice from the university.
I hope so.
It is gonna be. The ophthalmoscopy, the fundoscopy is not a common practice in our hospitals. For example, here in Bolivia, there's no doctor who makes it instead of the ophthalmologist. But in a hospital, in a private one. They had a crazy doctor, that was me, that was used to do it. And all of the doctors said, why you do this? Because you are not an ophthalmologist. I'm not looking for an ophthalmologist. I need to check that everything's okay, because this patient is young and it's without control. And there we found many, many situations for helping people, and that's the objective we have to consider. That's the idea. If we get, of course, I was telling you at the beginning and the model 1, if the brain has no idea what it's looking for, of course, eyes are going to forget all of the situations, are going to avoid real problems. So we must read, practice, and check and check and check and check. And don't be ashamed, don't be afraid about discussing a case or explaining x-rays, for example, or a CT scan. I'm going to show you lots and lots and lots of pictures. It's going to be so productive and fun. And on the internet, you can find full pages, full websites that explain you with a magnificent detail these structures in x-rays, in ultrasound, or procedures that are not usually to do. So take a deep breath. We are going to practice a lot. And I think it's all, that's all. If there's no question, let's fill the diary pool, the one we are used to do, in order to get assistance, okay?
Miss, I closed the pool.
Okay, don't worry, I'm going to relaunch it while finishing. Did you, Johan, did you fill the first pool, the first one?
No, I didn't.
Okay, I'm going to relaunch both of them, don't worry.
The first one, yeah. The second one, no.
Okay, the second one, I'm going to do it and have 8, yes. Give me a minute, please. I'm going to relaunch it. And if somebody, sorry. Okay, can you watch this now, Johan? Yes, perfect.
Yeah, I feel it.
Okay.
Thank you.
You're welcome.
Good night.
Okay, you're welcome. So see you tomorrow, everybody. Everybody knows this, the schedule you have. And anything, please let me know the situation as soon as possible. You have a trouble or something for asking permission and not coming. Okay, that's okay. That's all. And have a good night. We finished almost on time. That was the plan for today. Monday is going to be a hard situation. We're talking about lots of images and lab tests. I mean, I'm preparing it. It's a lot of information. I don't know how to get organized, but that's great. About homework, I'm sorry, I'm forgetting it. This week, this first session, I think I'm not going to send homework because it's too easy. Vital signs and the fundoscopy could be in the second week. I mean, first session with the second and the third, these three classes together in homework. I think it would be better for having a correct amount of work, okay? So, see you tomorrow, everybody. Goodbye.
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 See you tomorrow.
Bye.
Bye-bye. Well, everything said. I go home. Yeah, I go for rest.